bounding pulse, head nodding, and blowing murmur. These all have in common. They point towards one diagnosis, that is aortic regurgitation. I have covered the basics of aortic regurgitation in the short section. Do watch them. Now let us study aortic regurgitation in detail. Before starting with aortic regurgitation, let us see the anatomy of the aortic valve. Wherein the normal aortic valve have three leaflets, and this is the normal anatomy of the aortic valve. Wherein in the aortic regurgitation, the valve leaflets fails to pump the blood to the aorta. Let us define the aortic stenosis, wherein the definition says the aortic regurgitation is the retrograde flow of blood from the aorta back into the left ventricle during diastole. This occurs due to structural failure preventing proper valve closure. The structural basis here is the leaflet failure, wherein incomplete coaptation of the aortic valve cusp occurs, wherein the aortic valve leaflet do not close completely. Root dilation, wherein the widening of aortic root prevents the leaflet apposition, and combined pathology, wherein the leaflet failure and root dilation occurs. Hemodynamic changes are the wherein the aortic regurgitation imposes a dual burden. Volume overload occurs and pressure overload occurs. Ultimately, it strains the left ventricle. Now let us learn the classification of aortic regurgitation, wherein aortic regurgitation is of two types, that is acute aortic regurgitation and chronic aortic regurgitation. The causes of acute aortic regurgitation are infective endocarditis, aortic dissection, trauma, and prosthetic valve dysfunctions. For the chronic aortic regurgitation, rheumatic heart disease is the most commonest cause. Congenital bicuspid aortic valve, degenerative valve changes, and calcific disease are the commonest causes of chronic aortic regurgitation. The etiology continues, wherein the aortic root causes are aortic dissection is an acute emergency with sudden severe aortic regurgitation. Connective tissue disorders like Marfan syndrome and Ehlers-Danlos syndrome, hypertension, and syphilitic aortitis may cause aortic root disease. Iatrogenic and other causes like the post-procedure causes are the complications from balloon valvectomy or TAVR, that is transcatheter aortic valve replacement surgery. Drug-induced like ergots, alkaloids may cause the fibrosis of the valve. Autoimmune diseases like SLE, ankylosing spondylitis, Retter's syndrome, etc. are the iatrogenic causes of aortic regurgitation. Let us see the pathophysiology behind aortic regurgitation. In acute aortic regurgitation, it is a medical emergency. Sudden regurgitation into non-compliant and non-dilated LV causes a dramatic rise of left ventricular and diastolic pressure. This rapidly transmitted backward and causes acute pulmonary edema and cardiogenic shock. No time for compensation. In chronic aortic regurgitation, it is a silent compensation wherein gradual onset allows eccentric hypertrophy and chamber dilation occurs. This is a gradual onset of chamber dilation wherein LV accommodation increases the volume with preserved ejection fraction for the years. Patient remain asymptomatic for many years and for the decades despite severe regurgitation. The tipping point where eventually compensatory mechanism fails, the dilated LV transitions to the systolic dysfunction, that is ejection fraction less than 50%. Once this occurs, myocardial damage starts and it is a irreversible thing even after surgery. Now the pathophysiology, wherein the normal heart pumps blood from left ventricle to the aorta, and in aortic regurgitation, due to the leaflet failure, the blood backflows to the LV from aorta. Clinical features of aortic regurgitation are: for acute aortic regurgitation, sudden severe shortness of breath, Chest pain if myocardial perfusion decreases, hypotension may occur, cardiogenic shock and pulmonary edema can be seen. In chronic aortic regurgitation, the symptoms are initially the patient is asymptomatic, later it develops dyspnea on exertion, orthopnea that is breathlessness on lying down, PND, palpitations, coronary artery disease and congestive heart failure. Physical examinations, that is the signs of wild pulse pressure. Chronic aortic regurgitation produce a characteristic wild pulse pressure, that is elevated systolic and low diastolic blood pressure with numerous peripheral anomalous signs like Corrigan's pulse, that is a water hammer pulse. The characteristic of water hammer pulse is it rises rapidly and collapses suddenly is the characteristic pulse of aortic regurgitation. It is bounding carotid pulse with rapid upstroke and collapse, hallmark of severe aortic regurgitation. De Musset sign, it is rhythmic head nodding. Rhythmic head nodding is seen in the De Musset sign with forceful carotid pulsation. Twinkies sign is visible capillary pulsations in the nail bed with gentle pressure. It reflects wild pulse pressure. Austin Flint murmur is the mid-diastolic rumble at apex caused by regurgitation jet impinging the anterior mitral leaflet and mimicking as the mitral stenosis. There are other signs of aortic regurgitation like Traub's sign is the pistol shot sound over the femoral artery. Then we have Becker's sign, retinal artery pulsations are seen in it. Then we have Hill's sign, that is popliteal systolic blood pressure is more than brachial blood pressure by 20 millimeters of mercury. Now the blood pressure in the aortic stenosis is a typical, that is wild pulse pressure. On auscultation, now the auscultatory findings of aortic regurgitation, where it is a primary diastolic murmur. It is high-pitched blowing decrescendo diastolic murmur heard best at left sternal border with patient sitting up, leaning forward and inhaled expiration. Duration correlates with severity. Longer murmur, more severe aortic regurgitation. As much as the longer murmur is heard, that is the severity of the aortic regurgitation. Then we have the Austin Flint murmur, that is the mid-diastolic rumble at apex caused by regurgitant jet striking the anterior mitral leaflet. It mimics as mitral stenosis. Associated finding, just now I have enumerated, that is the Traub's sign, Duroch's sign and S3 Gallup and other signs like Becker's sign, Hill's sign, etc. are the signs of aortic regurgitation. The murmur characteristic, where the timing is the early diastole immediately after A2. Quality, it is blowing and high-pitched type of murmur. Location at the left sternal border. Radiation, it may radiate to the apex or the right sternal border of the heart. Modifiers like it is louder with hand grip and leaning forward, and on expiration the sound may get loud. Severity clue, where the murmur lasting through entire diastole suggests the severe aortic regurgitation. Let us learn the investigation part of aortic regurgitation, where we have the echocardiography, that is transthoracic echocardiography or transesophageal echocardiography. Then we have ECG, chest X-ray, cardiac MRI and aortography. The gold standard here is echocardiography, that is transthoracic or transesophageal is the gold standard for aortic regurgitation evaluation, wherein the regurgitation volume, the fraction, the orifice area, LV dimensions, ejection fractions, aortic root, etc. are all documented in echocardiography. ECG, where it shows LVH with strain pattern in chronic AR, and X-ray can help for the aortic root dilation. Cardiac MRI provides precise regurgitant fraction and LV volumes when echo is inconclusive. Aortography remains useful for surgical planning and especially in aortic root disease. The severity grading is done on the echo criteria where mild, moderate, mild is like less than 25 percent, moderate it is 25 to 65%, severe it is more than 65%, vena contracta more than 6 millimeters, and regurgitant volume more than 60 ml per beat indicates severe aortic regurgitation. Is the criteria for diagnosing aortic regurgitation, that is mild, less than 25%, then we have moderate 25 to 65% and severe wherein it is more than 55%. Diagnosis and clinical staging, where we have a structured approach combining echocardiography, severity grading, and clinical symptom status. Wherein at stage 1, that is stage A, at risk, that is bicuspid valve root dilation, normal echo, and monitor annually the patients. If it progresses, that is the stage B, mild to moderate AR, asymptomatic patient, LV size is normal, echo for every 1 to 2 years. If it progresses, that is at stage C, is asymptomatic and severe, that is severe AR by echo criteria, preserved ejection fraction, asymptomatic, echo for every 6 to 12 months, and consider surgery if ejection fraction drops. And if it progresses to the stage D, that is symptomatic and severe aortic regurgitation, wherein the patient's ejection fraction is less than 50%, now we need a surgical intervention for the patient. Key echo parameters for severity is the jet width, that is LVO2 width ratio more than 65 is equal to severe aortic regurgitation. Vena contracta more than 6 mm is severe aortic regurgitation. Regurgitant volume more than 60 ml per beat is severe regurgitation. Regurgitant fraction more than 50% and flow reversal in descending aorta, all are pointing towards severe aortic regurgitation. When to refer for surgery, the patient is symptomatic with severe aortic regurgitation, that is dyspnea, angina, syncope. Asymptomatic with left ventricular ejection fraction less than 50%, LV end diastolic dimension more than 50 mm, LV end diastolic dimensions like more than 65 to 70 mm, and undergoing cardiac surgery for other indications. Now let us see the treatment part for the AR, that is medical management to the surgical intervention. For acute ones, we need immediate surgical treatment as it is medical emergency. Acute severe AR, that is aortic regurgitation, causes hemodynamic collapse. Immediate surgery is mandatory. IV vasodilators like nitroglycerides and inotropes serve as bridge to surgery. IABP is contraindicated as it is contraindicated in the aortic regurgitation. Next we have the chronic aortic regurgitation. It has a staged approach, that is first is the medical therapy, then we have surgical indications and surveillance protocol. At medical therapy, we will start with vasodilators like ACE inhibitors like enalapril, nifedipine, calcium channel blockers that reduce the afterload and improve forward stroke volume, indicative for symptomatic patients, not yet surgical candidates, those with hypertension. We can treat them with medical therapy. Next, we have the surgical indications like aortic valve replacement surgery or the repair for symptomatic severe AR, asymptomatic with ejection fraction less than 50% and progressive LV dilation, we should do the surgery. Root replacement if root disease is present. Surveillance protocol where asymptomatic patients of severe aortic stenosis, echo should be done for 6 to 12 months. Monitor LV dimensions and ejection fraction. Patient education on symptom recognition is essential. Next, the conclusion part of the today's video, that is aortic regurgitation, is early detection is must. Timely intervention, that is surgery before ejection fraction falls, or acute aortic regurgitation needs medical management like it is a medical emergency, so it needs surgical intervention. Chronic aortic regurgitation we should do with staged approach, and key mnemonics wherein the water hammer pulse that is for physical signs, that is AR is equal to afterload reduction, wherein the water hammer pulse is the rapid rising pulse and rapid falling pulse. So sudden rise and sudden collapse of pulse is the water hammer pulse. Remember, this is the most important pulse of aortic regurgitation. Thanks for watching. If you understood today's topic, like, share and subscribe to my channel.